Hello friends, I am Dr. Chaitanya Buva, endocrinologist working in Nashik at my own Hormocare Endocrine Center. Today I am here and I want to share my experience and my views about one case scenario. So we will just go on with that. I just want to share one of the cases which I had recently came across. So this is one 57-year-old male patient. He has history of type 2 diabetes for last 5 years duration. And he was complaining of general weakness since last 2 months or so. He had history of acute coronary syndrome and hospitalization for that at least 1 year back. And in his treatment regime, which was ongoing, he was on glimepiride 2 milligram and metformin 1000 combination twice daily, BID dosing it was going on. Then he was on losartan 50 OD, protipine 5 mg OD, chlorthalidone 15 mg, metoprolol 50 mg OD sustained release, atorvastatin 40 mg OD, and aspirin 75 milligrams OD. So those were the medications which were going on in this case. When I evaluated, on evaluation, I found his fasting blood glucose was around 192. Postprandial blood glucose was around 240. HbA1c was around 8.9. eGFR was 88. Creat was 1.2. And LFT were normal. Electrolytes were normal. LDL level was 75. Urine routine was normal. Urine albumin creatinine ratio showed microalbuminuria. So the value was 150 milligram per gram. He was on obese side. So BMI was 31. Blood pressure was 120/70. Pulse was 78. So what we are finding in this case is we have a type 2 diabetes, around 57-year-old male patient with a background of coronary artery disease, and on evaluation found to have uncontrolled blood glucose levels, microalbuminuria. And he has his creat normal and eGFR was around 88. So that is the scenario. And now as far as his glucose management is concerned, now we all know on this background, he is having a risk of developing microvascular complications in the form of renal complications. And he already has established coronary artery disease. And on this background, we have to treat his blood glucose level. So our target is not only to achieve the HbA1c, but we have to even reduce the renal risk and even cardiac risk also we are supposed to reduce. So now what are the options before us for all these purposes? We can consider in this case different medications, for example, DPP-4 inhibitors, SGLT2 inhibitors we can add. The combination of SGLT2 inhibitor and DPP-4 inhibitor we can consider. Or we have options of glitazones, AGIs, insulin for blood glucose level control, or different combinations of these medications. Now, which will be the best option currently we can think of? In my view, what is happening here is he has uncontrolled blood glucose levels with HbA1c of around 9%. And I think he will not be managed with only one medication except insulin, because he's already on maximum doses of metformin, near maximum doses of sulfonylureas. And so other medications, they cannot reduce the HbA1c to our target of 7. So I think we should have a combination. That's what I feel. And here also, the best options will be, if cost is not the issue, then the best option will be the combination of SGLT2 inhibitor and DPP-4 inhibitor. That's what I feel, because we do have a very good scientific evidence until now through different clinical trials that SGLT2 inhibitors, they significantly reduce the cardiac risk and renal risk also. So empagliflozin especially has shown its promise in reducing the cardiovascular event rates, cardiac death and overall death rate also is found to be reduced. It has shown to reduce renal complications also. One option in combination with that will be gliptins, and in that linagliptin has shown, in Carmelina trial, it has shown very good evidence that at least it is not inferior to the placebo in terms of cardiovascular risk, and it reduces the renal risk by reducing the progression to the microalbuminuria. So the progression of renal disease will be halted, or it will be reduced by linagliptin. So I think as far as the scientific evidence is concerned, the combination of gliptin and SGLT2 inhibitors, and that too, one of the best combination here we can think of is linagliptin and empagliflozin, that will be the best situation as far as the scientific evidence is concerned, because it is going to benefit his blood glucose levels. HbA1c can be achieved well to the target with this combination. Then it can reduce the renal risk, it can reduce the cardiac risk, it can reduce the weight, it can have a good effect over the blood pressure. Only thing is we have to think of discussing with our cardiologist colleague in order to reduce the diuretic doses and antihypertensive doses if it is needed in this case. That's what we have to see. And we have to control his blood glucose levels, lipids, weight, LDL cholesterol to the target in order to achieve the overall success rate in this case. And I think that is the best combination. And this combination, linagliptin and empagliflozin, both are working by different mechanisms of action. So they will have additional effects over the effectiveness and complementary actions over the effectiveness as well as the safety, because it has been found that over and above only empagliflozin, addition of linagliptin to empagliflozin can reduce the complications of genital mycosis. That can be reduced to a certain extent with this combination itself. So it will be a safer option, it will be an effective option, and it will be a multi-effective option in this case. And I think linagliptin plus empagliflozin, that should be the choice in this case scenario. That's what I wanted to discuss with you, all this case scenario and my views and my experience in this case. And I added empagliflozin plus linagliptin combination, and HbA1c was reduced without any significant complications, and the case went on well after that. So I just want to thank Lupin for giving this opportunity to me to interact with you all, for sharing my experience and my views on this particular topic. And I thank you all, friends, for listening to me. Take care and all the best to you. Thank you very much.